Hi, not an ordinary fellow here, and I got a page. Okay, so this time, Dr. PCP asked me to see this 55-year-old Caucasian female that had an abnormal mammogram and is seeking for advice. Can you help me with this one? For sure, Dr. PCP, but as you know, I'm a very young fellow, so I need to understand breast cancer before I see this patient. So let's crack breast cancer. So let's talk about the epidemiology. So breast cancer is the most commonly diagnosed cancer worldwide, including low and middle income countries. The incidence is highest in North America, Western and Northern Europe, and lowest in Asia and Sub-Saharan, I probably butchered Sub-Saharan Africa. Studies of migration to the United States are consistent with the importance of culture and environment changes. In general, the incidence rates of breast cancer are greater in the second-generation migrants and increase further in the third and fourth generation. So again, clinical features. So most patients will present to the clinic with an abnormal mammogram because most of the patients will have access to mammograms. 15% of the patients will present with breast mass that unfortunately was not detected on mammogram. So those patients were doing mammograms, but for some reason the mammogram wasn't able to diagnose the breast mass. So it happens in 15% of the patients. And in 30% of those patients, they will have a breast mass that was not there in the previous mammogram. So it was a new breast mass that was found in the interval between mammograms. So the presentation of a breast mass is a classic cancerous lesion. So it's a hard, immovable, single dominant lesion with irregular borders. Signs of a locally advanced disease. So when you see a patient with breast cancer, the physical examination is very important because then you can look for axillary adenopathy, skin changes such as erythema, thickening, or dimpling of the overlying skin. So that's also called peau d'orange. I think probably I butchered that also. And those changes, in the breast, they suggest inflammatory breast cancer. And if you think about metastatic disease, of course, every patient with breast cancer, you should look for signs of metastatic disease. They will have bone pain. They may have some liver issues, cholestasis or liver pain. They may have cough or shortness of breath. The imaging, usually it's a mammogram that you have. So the classic mammographic findings include the presence of a soft tissue mass or density and clustered microcalcification. The most specific feature is speculated soft tissue mass, with nearly 90% of those speculated soft tissue mass representing invasive cancer. So the ultrasound is also something that you may have or you can order, and it will help you to distinguish between a malignant and a benign lesion. So the ultrasound feature of a malignancy will include, of course, the speculation, hypoechogenicity, microlobulation, internal calcifications, shadowing, in a lesion that is taller than it is wide and with angular margins. MRI, breast MRI can also be ordered, and it can also be used for screening for patients with a high risk of breast cancer, especially young patients. So nearly all invasive breast cancers enhance on gadolinium contrast enhanced MRI. Um, of course, just having MRI is not specific enough to avoid or obviate the need of a biopsy. So pathology. So the most important test that you will have when you think about breast cancer is the pathology, because as most cancers, 99% of cancers, you're gonna need pathology to make the diagnosis. So there are various histologic types of breast carcinoma, and the most common is the infiltrating ductal carcinoma, and that represents 70 to 80% of the breast cancers. So those lesions are characterized by cords and nests of cells with a varying amount of gland formation and cytological features that range from bland to highly malignant. So infiltrating ductal cancer is the most common type, 70 to 80%, and the way it looks is like cords and nests of cells. So other types of breast cancers, you can have the infiltrating lobular carcinoma. Infiltrating lobular carcinoma, only 8% of the invasive breast cancer. So those are small cells that insidiously infiltrate the mammary stroma and adipose tissue individually and in a single file pattern. Well, you have to remember that it's the second type of a breast cancer. So it's an infiltrating lobular carcinoma, 80% of the cancers. Next type of cancer that you can have, the mixed ductal lobular carcinoma. So 7% of the cancers, and the other types are more uncommon. So you can have metaplastic, you can also have mucinous, tubular, medullary, and papillary. So just to remember again, infiltrating lobular carcinoma is the most common type, 70 to 80%. Then you have infiltrating lobular carcinoma, 8%, and then mixed ductal lobular carcinoma, 7%, and then the rest. So molecular subtype. So people are really looking into the molecular subtype and gene expression profiles of the cancers. Okay, so they have several molecular subtypes. So the first one that we'll talk about is the luminal subtype, and that can be A or B. So the luminal subtype is the most common subtype of breast cancer, and it's the majority of the ER positive breast cancer. We're going to talk about ER positivity and how that's important. But remember that if you have the breast cancer that express estrogen and progesterone, most likely that will be the luminal subtype, and this is the majority of cases. Luminal derives from the similarity in gene expression between these tumors, the breast cancer, and the luminal epithelium of the breast. So it looks like, in terms of genetics and gene expression profiles, it looks like a luminal epithelium. And they typically express cytokeratins 8 and 18. So the other type of molecular subtype that you can have is the HER2 enriched. So you have probably you heard about the epithelial growth factor 2, HER2. So I'm not talking about HER2 per se right now. I'm talking about the molecular subtype. So the molecular subtype HER2 enriched is a subtype that is only 10 to 15% of the breast cancers, and is usually characterized by the high expression of HER2 in the proliferation gene clusters and low expression of the luminal and basal gene clusters. So HER2 enriched usually will have a high expression of HER2 in the proliferation gene clusters. Also will only be present in 10 to 50% of the breast cancers. Um, they can be often ER and PR positive, and only 50% of HER2 positive breast cancers are actually HER2 enriched breast cancers on the molecular profiling. So don't mix the two things. So just because you are expressing HER2 in the biopsy, it doesn't mean that this cancer is HER2 enriched molecular subtype. And then you have the last one, so the basal subtype. And basal subtypes usually are triple negative. So triple negative is a concept that we'll talk about, but it is essentially a cancer that does not express ER, PR, or HER2, and the molecular subtype will be basal. So we have now come to the diagnosis, and it's pretty easy because we don't need anything else other than a biopsy. And the diagnosis is made with the presence of malignant epithelial cell, so carcinoma, and differential diagnosis so it's a pathological differential diagnosis and must include other breast lesions beyond the invasive breast cancer. So we have to think about things that are not cancer, for example. So ductal carcinoma in situ, DCIS, ductal carcinoma in situ, is a precancerous lesion and potentially a precursor lesion to invasive breast cancer. The second type of differential diagnosis is the microinvasive breast cancer, and it usually presents as a palpable mass, and it is an invasive carcinoma of the breast where the largest focus is no more than 1 millimeter. So very small invasive carcinoma, but with the largest focus no more than 1 millimeter. And the other type of neoplasia, so although not common, you can have breast sarcoma, you can have lymphoma of the breast, also Paget and phylloids, which is a benign tumor, but also requires treatment for sure. So now we go to the post-diagnosis evaluation. So if cancer is identified, so then you have to look in the hormone receptor status, because the hormone receptor status, as you'll see later, is key for the treatment and how we'll manage this patient. So patients should proceed with an appropriate staging, workup, and of course to determine local and distant extent of disease. So women presenting with signs and symptoms of metastatic breast cancer should undergo additional imaging. If you have signs of metastatic breast cancer that so for example, if you're losing too much weight, or if you have back pain or neurological symptoms, so you should undergo additional testing. If you don't have it, then it's generally not recommended to just imaging the patient. A biopsy should be done of at least one of the metastatic lesions if you saw that lesion in the imaging, and that's to confirm a diagnosis of metastatic breast cancer. So if the patient has symptoms of metastatic disease, and that means severe weight loss, cough, chest pain, in an area that is not in the breast, or like headaches, probably you should do further imaging with MRIs and even PET-CT. And then if you find something, then you should do a biopsy to confirm the diagnosis. So breast cancer receptor testing, this is key for the diagnosis. So newly diagnosed breast cancer must be tested for ER and PR reception expression. They should also be tested for the overexpression of the human epithelial growth factor 2, HER2 receptor. So ER/PR HER2. ER positivity is defined by immunohistochemistry, the IHC, for ER and PR with more than 1% of tumor cells. So if you have 1% of tumor cells that were positive for ER/PR, you're considered to be positive. But HER2 is a different situation. So the overexpression is present in 20% of patients, and will predict response of HER2-directed therapy. So it will detect by uniform intense membrane staining of more than 30% of invasive tumor cells. So in immunohistochemistry 3+, or the presence of of a HER2 gene amplification by FISH, defined as a ratio of HER2 over SEP17 over 2. So you need to have immunohistochemistry that is 3+. So there will be over 30% of the invasive tumor cells, or FISH. So if you have FISH, that will be positive. So if you have immunohistochemistry with a low number, but you still have a FISH that's positive, so this is considered to be HER2 positive. I'm gonna make a video later on about that, because I feel that it can create lots of doubts. And what's the frequency of the subtype? So ER and or PR positive are 80% of the cases. So most of the patients will be ER/PR positive. HER2 overexpression is in 33% of the cases, and of those 70 are hormone positive and 30 are negative. So if you are HER2, probably you're gonna be ER/PR positive, but if sometimes in 30% of the cases will be negative. And the triple negative, meaning ER/PR HER2 negative, is seen in 13% of the cases. The whole of imaging. Imaging is reserved for advanced or metastatic disease. And you're gonna do imaging if you have a patient with bone pain or elevated alkaline phosphatase. Because if you have elevation of alkaline phosphatase, you may have it from the liver, or can also be from the bone. So if you have a patient with symptoms of bone disease, you should do a bone scan. If the bone scan is negative, but you're still concerned about metastatic disease to the bone, you should do MRI. Abnormal liver tests in elevated alkaline phosphatase, abdominal pain, and abnormal pelvic examination or some of the things that make you consider further testing as a CAT scan of the abdomen. You can also, of course, always do a PET-CT, MRI, or even an ultrasound. If the patient has pulmonary complaints, so it's reasonable to order a CAT scan or even a chest X-ray, of course, after a physical examination in a proper history. For patients with stage 3A or higher, um, you can order a PET-CT or a bone scan, as well as a CAT scan of chest, abdomen, and pelvis. This is because if you have an extensive disease as 3A, the likelihood of having metastatic disease is higher, and then you should look for metastatic disease, because there will be different treatments. Because if you're 3A, probably you're locally advanced, and that will have a different type of treatment. But if you have metastatic disease, it will go to another direction and the treatment will be different. So PET-CT is not indicated for patients with early stage, meaning 1 or 2 breast cancer, and those with operable stage 3 breast cancer. So PET-CT not indicated to everybody, especially if it's early stage and operable, but can be done if you suspect metastatic disease. So assessing the extent of disease. So mammogram of both breasts is always recommended, especially if you're considering breast conservation therapy. Because of course you need to know if you have lesions in the other breast. So preoperative diagnostic mammogram can help define the extent of disease and also may identify multifocal or multicentric cancer. So what's multifocal cancer? So it's defined as involvement of several areas within the breast quadrant, probably representing disease along the entire duct. So multifocal is more focal, it's more in a duct, and represents disease in the entire duct. In the other hand, multicentric disease involves multiple areas with different quadrants, so more extensive. Multifocal is in a duct in a quadrant. And multicentric will have multiple areas with different quadrant. And also, after the diagnosis, you can do post-operative mammogram to look for residual calcification after the surgical resection, especially because if when you did the specimen radiograph after the surgery and you saw microcalcifications, and also if the margins were close or positive. So mainly the mammogram, the post-operative mammogram, is to look for the residual calcifications after the surgical resection, and that should be done in patients with that they had the surgery and the microcalcifications were not well seen, the radiograph after the resection, and the margins were close or positive. So in patients that are younger, they can have dense breast, and that can limit the sensitivity of the mammogram for the detection of the breast cancer, and also to delineate the extension of the disease. So in that sort of patients, MRI can actually help to complement the mammograph findings. If clinical extent of disease is larger than was appreciated in the mammogram, MRI may be considered. So pretty much when you have a breast cancer, a breast that is very dense, and you want to delineate the disease, then you can order MRI. Also, when you do the physical examination and you pretty much think that the disease is larger than what you saw in the mammogram, so then you could order MRI. And also for young patients that are in high risk, so you do the screening. So the significance of intramammary lymph nodes. So sometimes you can see that in the mammogram or the ultrasound. So the intramammary lymph nodes, they can be detected in up to 1 to up to 28% of patients with breast cancer, and they can be distinguished from metastatic from benign by the way it looks in the mammogram or the ultrasound. So the presence of intramammary lymph node metastases confers a worse prognosis. Both stage 1 and 2 disease will have a worse prognosis with that. Isolated intramammary lymph node metastases are considered per se to be stage 2. So if you even if you have a very small lesion, the fact that you had intramammary lymph node metastasis, that will be stage 2, even if the axillary node is negative. So staging, so in January 1st, 2018, we had a new TNM staging from the American Joint Committee of Cancer. Probably we'll talk about that later on. So TNM clinical stage is you're gonna see that as a C TNM. After surgery, people like to restage the patient with a P, so you're gonna see a PTNM. So CTNM is the clinical staging. So based on what you saw on the ultrasound, the mammogram, and your physical examination, you're gonna say that the clinical stage is so and so. After the surgery, then you're gonna have the pathology, so we can actually say, oh, the lymph nodes were involved, the size of the cancer was so and so. So then you can write it as a PTNM. For patients who undergo neoadjuvant treatment, so neoadjuvant is when you give chemotherapy prior to surgery. So you gave chemotherapy or like any kind of treatment. You can also do other types of treatment that are not chemotherapy. But if you gave a neoadjuvant treatment, the final pathological stage is designated by the letter Y. So there will be YPTNM. And that's because sometimes when you do neoadjuvant chemotherapy or treatment, you can downstage the patient. And the lymph node status of the regional lymph nodes is the most important prognostic factor in early stage breast cancer. So you should do a very good physical examination and also see the results of the pathology. So that was it. It's just a overview about how to look into a patient with breast cancer. In the next video, we'll talk about treatments and other things that are very important as well. So keep subscribing, and I'm gonna upload lots of content so people will be up to date regarding the how to deal with patients with hematological diseases or oncological diseases too. Thank you.